Hi, is this Dr. Garcia's office?
Hi, this is. Who is this?
Hi, my name is Becky. I am hoping to make an appointment for a pneumovax vaccine. You can sit in order.
Yeah. All right, we're going to go ahead and get started. I know everybody's really tired. We're last session of Friday. Thanks for sticking it out with us. Just a reminder, we are in session 22. So if that's not the session you're looking for, let us know and we'll get you to where you need to be. As I'm sure all of you are aware, we have some CEUs and we're asking that you use our QR code to sign in for those, as well as fill out our session evaluation form. And before we get started, just want to make sure, I think we only have a few people on, if we can hear, okay? Online, yes, no? No answer, so we're gonna assume that you can hear, and if you can't hear, please let us know in the chat. And without further ado, I'm gonna turn it over to our panelists today, and they'll introduce themselves, so. This should, yeah, give it a, oh, let me do it.
There we go. All right, well, good afternoon, everyone. My name is Isabel Garcia. I'm a second-year medical student at the Ohio University Heritage College of Osteopathic Medicine, or OUHCOM for short. My team and I also represent the Cleveland Clinic through the Transformative Care Continuum program, which we'll go into later. And we'll be talking today about our project titled Bridging the Gap, the Pneumococcal Vaccination in Adults with IDD. There we go. Okay, so here's our agenda for today. We'll go ahead and introduce the TCC program. We'll then talk about the health disparities within the IDD community. We'll then go on to discuss our community engagement quality improvement project. We'll finish up with our major takeaways, and then we'll follow up with some questions. And we ask that you keep any questions that you have to the very end, please. So here's our team. We are part of the class of 2023, and we're all second-year medical students at OUHCOM. So I'll let my team go ahead and introduce themselves.
Hello, my name is Frankie Kokos, and as Isabel mentioned, I am also a second-year medical student at OUHCOM.
Hi, my name is Rebecca Plow, and I'm a med student as well.
Hi, I'm Vanessa Vasquez and also a second-year medical student.
Hi, I'm Matthew Wagner. I'm also a second-year medical student, and I work at the Lakewood Clinic for Cleveland Clinic.
And then hello, my name is Salam Picard. I'm also a second-year medical student.
All right, and then also pictured here is Rebecca Bracken. She was unable to make it today. So we want to start off by talking a little bit about our program, the Transformative Care Continuum, or TCC for short. And what we are is a 6-year accelerated family medicine program. And we focus on 3 aspects. That is our medical education, population health and health systems, and community partnerships. So to begin with our medical education, we complete 3 years of medical school compared to the traditional 4 years, and we do that at OUHCOM. Then we move on to our 3 years of family medicine residency at either the Cleveland Clinic Akron General Center for Family Medicine or the Lakewood Center for Family Medicine. And what's unique about our program is that even before we start our medical education, we all know where we're going to residency. So half of us go to residency at Akron General, the other half go to Lakewood. And so that's really unique because traditionally medical students are matched into their residency programs within their 4th year of medical school, which we don't experience. And then we go on to our family medicine residencies. So that's really nice because throughout our 1st, 2nd, and 3rd years, we are simultaneously trained at the sites that we will one day be residents, and we get to know the staff, get to see patients that we one day will be able to treat. So it's very unique and we all love it a lot. Also throughout our education, we also take extra classes about the foundations of family medicine, how to be a good doctor, how to be patient-centered, learn about social determinants of health and how that impacts patients. So that's also a great aspect of our program as well. And that's run by our program director. Her name is Dr. Leanne Chrisman Kawam. She is a family medicine physician with Metro Health, and she also works with the Cleveland Clinic through our TCC program. Secondly, at the very beginning of our program, we all learn about how systems in general play a huge impact in patient outcomes and population health. So from the beginning, we are taught about quality improvement and how to utilize that within the health system to improve patient outcomes. So we all build our own projects from the ground up. We find different problems within our clinics and create these projects in hopes of making a difference within our health system, with the clinic, or with patient outcomes. And we're also certified in Lean Six Sigma. And if any of you are not familiar with that, that's a quality improvement program where you get different skills, techniques, or ideologies about how to make a substantial change within systems. And lastly, our program highly emphasizes the importance of community partnerships within the practice of family medicine. So within our third year of our medical education, all of us create our own community projects. And what we do is that we find a healthcare gap within our Akron or Lakewood communities that we are passionate about. We then find a community organization for us to partner with, and then we create some type of intervention project or community like outreach to address a certain healthcare gap that we enjoy. So in the past, we've had our most recently graduated class, who was the inaugural class, make really great projects relating to PPE distribution. We had some people address food insecurity. We had one person do HIV testing in the housing insecure population. And that project actually won a CDC Public Health Award. So as you can see, these projects really do make a difference, and it's something that we all are passionate about. So just to focus on community partners in general, or specifically, our first experience with community partnerships happened right after our first year of medical school during our summer term. So we create these community projects throughout the summer, and we work with clinic staff to identify a need within our community. And we'll kind of jump into that further on when we talk about our project. But we identified that patients with IDD were our population at risk and wanted to work with that community. Sorry, I don't know why this isn't helping me today. Are you able to advance it in the back? I'm not sure. Oh, there we go. So I know a lot of you are familiar with what IDD stands for, but just in case anyone doesn't know, IDD stands for intellectual or developmental disability. And the formal definition of it is a severe long-term disability beginning prior to age 22 that affects cognitive functioning, physical functioning, developmental adaptive skills, or some combination of those impairments. So about 4.5 million people in the United States have an IDD, and some of those are autism spectrum disorders, cerebral palsy, chromosomal and genetic disorders, among many others. And we just wanted to note that although there are these very specific diagnoses, every person presents in their own way. They all have their own very individual experience, and therefore their care must be catered to their own experience rather than just general ideas and assumptions.
So hello again. As I mentioned prior, my name is Frankie Kokos, and I'm just going to talk to you a little bit about the atypical populations within healthcare and the stigma that we have found in the IDD community with healthcare practitioners. So I'm sure we have all had very positive experiences working in the IDD community, but I just wanted to reach out and see if anyone had a particularly bad experience or something that rubbed them the wrong way working with the healthcare professional field and a patient with IDD. So would anybody be willing to share a story? Anyone have one? Mm-hmm.
It's just that they're not treating the patient,
Mhm.
but it's not person-centered. It's just this doesn't work. Let's add on something outside of something else, or that not having that communication among healthcare partners.
Perfect.
Constantly want to care reform to begin with. We've had practitioners who would just straight up refuse when
Mhm.
they have found out that it's just don't even want to see them.
Yeah, thank you for sharing. Does anybody else have anything else they'd like to share?
Practice, they just push them off like it's.
Exactly. And we as medical students have particularly noticed this, and our program director has placed a great emphasis on the patient-centered model. And our medical school as a whole has actually switched its curriculum within the last 4 years to a more patient-centered approach to medicine. So as I was stating before, and all of you have mentioned, unfortunately, there is a huge healthcare gap when it comes to the IDD community. And we as medical students have noticed that there is like a substantial gap in education. So in our undergraduate medical education, we are receiving no introduction, no education on the IDD community. Additionally, in our graduate medical education, we're receiving no education, no introduction to the IDD community. So what I mean by that is when we are in our initial, so we do 3 years of undergraduate medical education. Most of our classmates do 4. Most medical students in the country do 4. Throughout that 4 years, we get 1 week. 1 week of education on the population with intellectual and developmental disabilities. Yes, that is what is required by the United States for medical education. Fortunately, our program places a bigger emphasis on this. And we have seen a great care gap, not only in current practitioners, but in our classmates and residents. And so we wanted to really focus our project around this. And because of this lack of education, this leads, as you were mentioning, to this huge issue where you are graduating physicians and other healthcare professionals that are not prepared to care for the IDD community. They don't have the interpersonal skills to interact, to build relationships, and to form quality care partnerships with these patients. And because of this, these patients are having more adverse experiences. And as family medicine future residents, we have seen this great issue with the fact that as patients age out of the pediatric system, because traditionally pediatricians provide great care to these patients, as they age out of the pediatric system and go into family medicine or internal medicine at the age of 22, the transition of care is just catastrophic on them. And we just really wanted to focus on that and get a greater skill set in this specialized population. So now I'd kind of like to talk more specifically about some of the health disparities and the community that is at risk, the IDD community. So disparities in the healthcare position individuals with IDD more likely to experience negative or poor prognosis. So for example, a patient with an IDD is more likely to be hospitalized. They are more likely to have a longer hospital stay. And following discharge, they are more likely to have more issues after their discharge, you know, maybe having to go back to the hospital for a readmission, maybe having to go to an advanced skill nursing center, maybe having, you know, multiple follow-ups. And that just places an extra stress, not only on the individual, but the healthcare system as a whole. And additionally, they also have a higher rate of mortality from their illnesses. So we've seen this like particularly, obviously, because of the pandemic, this has brought like a great need and exposure to the issues within our healthcare system, and patients with IDD are at even higher risk for these issues. So if they were to contract COVID, they would be more likely to be hospitalized. They would be more likely to be intubated. And I'm not sure if all of you are aware, but if you get intubated, it's very highly unlikely for you to be taken off of intubation. It's more likely for you to, you know, pass away than it is for you to be taken off of intubation. And if our patients with IDD have this situation, it only makes them at greater risk. So we wanted to kind of focus in on preventative measures. So I'm not sure if any of you are aware, but there are pneumonia vaccines available. And pneumonia is a huge issue when it comes to COVID particularly. So unfortunately, there are no standard methods of vaccine schedules for the IDD population. And knowledge of eligibility about whether or not a patient with IDD can get a pneumonia vaccine falls onto the shoulders of the physician or the healthcare provider. And as I've mentioned before, they are not trained well enough to acknowledge these issues. So traditionally what happens with the pneumonia vaccine is you get 1 dose at the age of 65. And then 1 year later, you get your 2nd dose. Now, if you have other health like disparities, for example, heart disease, or you have asthma, you're eligible at an earlier age at 50. And as I'm sure all of you are aware, a lot of patients with IDD have other comorbidities, which makes them eligible at the age of 50. So knowledge of this eligibility falls onto the healthcare provider, but it also falls onto the caretakers and the patient themselves. So that's kind of why we wanted to focus our project around. No, you're fine. All right, so I kind of wanted to just discuss intellectual and developmental disabilities and concurrent conditions. So a lot of our patients with IDD have spinal cord compression, they have recurrent aspiration, which often leads to pneumonia. They have coronary heart disease, or they have seizures. And the three most common causes of death in the IDD population differs from the general population. So we have the three main causes listed here. So heart disease, respiratory disease, and cancer. And a lot of our patients with IDD are at higher risk for all of these. So for example, a patient with Down syndrome is more likely to have a congenital heart defect. They are more likely to have asthma. They are more likely to have aspiration pneumonia, and they are more likely to acquire leukemia. So we kind of chose to focus in on this respiratory disease because there is this known vaccine that is available. And now I kind of would just like to summarize this and speak about the presentation of pneumonia. I know a lot of people are familiar with the fact that there is something called walking pneumonia. So you might not be super familiar with the presentation, but the standard presentation for pneumonia is obviously cough, shortness of breath. They might seem a little fatigued. Pneumonia is transmitted via sneezing, coughing, and inhalation. So fortunately, one benefit of the pandemic, as we've all been wearing masks, is that airborne illnesses have gone down. I'm not sure if you guys have noticed, but like you probably haven't gotten the cold, you probably haven't gotten the flu, luckily because of masks. So this has helped a lot. And we kind of like to approach this in a self-efficacy kind of way, like promotion of wearing masks in our IDD population. And pneumonia and pneumococcal disease. So pneumococcal is the bacteria that causes pneumonia. It can cause other things other than just pneumonia. So it can cause bacteremia, which is a bloodstream infection, which is very, very dangerous. It can cause meningitis, which is swelling of the meninges within your brain, also very, very dangerous. And it can cause sinusitis, which is a pretty severe sinus infection. And invasive pneumococcal disease can also cause brain damage, seizures, and hearing loss. And obvious, of course, it can be fatal, which is horrible. We would never want that outcome. So as I mentioned, and as Isabel mentioned, we are paired with the Cleveland Clinic. So we had the opportunity over the summer to kind of study our data within our health system. So as you can see here, 50% of our patients with IDD that are over the age of 65 were vaccinated for pneumonia. So they're not even meeting the standard of care for the typical population. Ideally, which is over here, 90% of our cohort at the age of 65 should be vaccinated for pneumonia. So our patients with IDD that are the age of 65 are not even being treated the same at this typical age of vaccination at the age of 65, even though many of them can be vaccinated at the age of 50. So no clinical guidelines are in existence for this, but clinical guidelines are in existence for other comorbidities. So for example, like I mentioned before, if a patient has heart disease, they are more eligible. And this eligibility and this knowledge of this eligibility falls onto the healthcare professional.
All right, to kind of what I think is the cool part of this is our project and how we chose it. So as we've been saying this whole time, partnership is kind of where we began, and we were able to coordinate with a family physician at Lakewood, and he specializes his practice in the IDD community, and he also specializes in the aging population. When he first began practicing, he was in a very unique situation where deinstitutionalization was occurring and patients with IDD were flooding into the family physician and primary care practices, and no one was ready. And we still see these disparities today. A lot of times people are not ready to fully treat patients with IDD. So we got to hear his perspective and some of his research and changes that he's made. And then we were also able to connect with community partners and patients. And through this, we met with them in kind of a town hall style meeting in which we got their feedback, asked what they wanted, what their concerns were. And that's how we really narrowed in on the pneumococcal vaccine. And they asked us to create education for the community. They asked us to create education for doctors, and they asked us to create education for patients. So that's kind of how we began. And our goal really landed on how can we get into the community? So we focused on day programs, and we wanted patients to have more self-advocacy and self-efficacy. There's no reason why our education should not be directed at patients. We also wanted to have higher confidence in the staff at these places, like with helping their clients get the vaccine. And then finally, we wanted to educate healthcare professionals.
As for our methods, we began with community partnerships. We did a pre-survey, an education intervention, which included a skit, a lecture, sort of, and patient education materials, and then a post-survey to see, did anyone learn anything from this? Our timeline was really fast. It was only 4 weeks long. We started with EMR data analysis, and we used the EPIC slicer dicer to kind of see where the disparities lie. And then we began brainstorming and learning how we could serve the IDD populations. We also reached out to our community partners, as we've been mentioning, to, gauge interest, because we can't just come in, helicopter in with our idea, not asking what can we do for you. And then we began planning and creating our materials. And then lastly, we got to visit our sites and test out our information. The partners that we had were Kuanania, Welcome House, and Ardmore Inc. They're all very similar in that they are the day hab programs, and that they have engaging activities for patients looking to return to work or just looking for support and socialization. As for our lecture, we wanted to include what is pneumonia, what are shots and why are they important, what is a buzzy and what is a shot blocker, which we'll get more into later, and then talking about our emotions around shots and just conveying how we feel. Our skit that we did involved a doctor, a patient, and a friend. So on our next slide, we have our skit, which is really cheesy, but hopefully you'll enjoy it. We're not meant to be actors here.
Hi, is this Dr. Garcia's office?
Hi, this is. Who is this?
Hi, my name is Becky. I am hoping to make an appointment for a pneumovax vaccine.
Awesome. You can come in today and we'll get that all set up.
I'm a little nervous about the vaccine. I was wondering, do you have any recommendations?
Yeah, so we actually have this thing called the buzzy that can help numb your pain before you get the shot. Is that something that you'd want to try out?
Yeah, that sounds great. Could I also bring a friend?
Of course, you can bring a friend.
Okay, great. So I'll come in this afternoon?
Yes, we'll see you later, okay?
Bye.
Bye. Hello?
Frankie?
Yes.
It's Becky.
Hi, Becky. How are you?
I'm good. Well, I'm a little nervous. So I have a predicament. I'm going to get a vaccine today and I'm a little scared. I was wondering if you'd want to join me today?
Of course. Vaccines can be scary, but I'll be there to support you.
Thank you. So I'll pick you up on my way, maybe 3?
Sounds good. See you then.
Ta-ta. Come in.
Hi, Becky.
Hi, yeah.
Hi, I'm Isabel. Nice to meet you.
Hi, Dr. Garcia. Thanks for making time for me today.
How are you today?
I'm a little nervous.
Yeah, why is that?
Well, I don't like needles. I don't like getting shots and things. And I know we talked earlier about getting this vaccine, but I'm still a little nervous.
Yeah, well, we have some things to help you out today.
I also got my friend Frankie to help me.
Hi, Frankie. Nice to meet you.
Nice to meet you.
All right, so you ready to get your shot?
Ready
Okay,
as
let me
ever.
show you this. So we have this buzzy, and if you want to feel it, it'll vibrate, and I'll put that on your arm right before we give you the shot, okay? And that should help with some of the pain, okay?
Okay.
All right. Are you ready?
I guess.
All right, I'm just gonna leave this here for a little bit.
Oh, wow. Okay.
And then you
That's
ready
not
for the
scary.
shot?
Yeah, Frankie. All
Ready?
right.
1, 2, 3, go. All right, how was that?
Wow, you're done already?
Yeah, you did it.
Great job, Becky.
Thanks, everyone.
You did it. Good job. Thank you for coming, Frankie. That was awesome.
Of course. I'll bring Becky when I get mine.
Cool, and hopefully you will always have the buzzy to help you, okay?
Yeah.
Yes. Yeah, so hopefully you enjoy that little skit. When we actually went to our sites, we did them live performance. So it was one of us being a doctor, one of us being the patient. And sometimes we got the clients to be part of the skit and got them to engage as being clients or patients or friends of the patient. But in addition to that, we also had infographic social stories that talked about the pneumonia vaccine, pneumonia in itself, and then the shot blocker and Buzzy, which are pain desensitizing tools. Social stories have been known to show, to be able to use as a tool to relay information in the population with IDD. So it's a good way for us to share the information not only to the clients at the day hab centers, but also to their families when they got to go back home, and any caregivers that were present at the sites. So here's the pain desensitizing tools. So these are designed as a non-pharmacological tool so that people can use while they're getting shots or other phlebotomy procedures like needle sticks or IVs. And they're meant to desensitize the nerves that are with the pain desensitizing nerves in your body. So I'll give you guys a few seconds to kind of try those out. No, unfortunately, we did not invent the Buzzy. And we're also not sponsored, but it's a tool that when we went out to our sites, we found out that many individuals, staff and clients weren't aware about the Buzzies. So it's one of the ways that we kind of demonstrated how to use them. Yeah. So that was one of the methods and part of our education intervention. And so in addition to doing the education, like Rebecca mentioned, we surveyed the clients at the site, as well as some of the staff that was available pre-education and post-education. And then just kind of, wanted to gather their thoughts on what they thought improved in terms of self-efficacy and self-knowledge. And so our results are here in 2 seconds. Go back. No, and one more. There you go. Very sensitive. I think 2, one, the next one. Yeah. There we go. Okay, so here are our results. So like we mentioned, we went to 3 day hab centers around Northeast Ohio, and we did a pre-survey and post-survey. Pre-survey is noted in blue. Post-survey is noted in green. Overall, we had 21 clients, and these are clients with IDD that took our survey, did our education, and then did our survey again to measure whether their confidence had improved in terms of knowing about the pneumonia vaccine, knowing more education on pneumonia, and then knowing about the desensitizing tools and how to ask for them in the case that they needed one and how to use them. So overall, there was significant improvement. And we actually did a small statistical test to make sure that there was significance. And even with our results that are fairly small, we were able to get a significance that shows that our education helped improve their self-efficacy and self-knowledge. So our limitations on this study, of course, this was piloted. Like Rebecca mentioned, we had to gather all this up in about 4 weeks, or it was very time sensitive. But even though it was small, we did get a good distribution geographically. We had a site down at Akron and 2 sites up on the west side of Cleveland. So that was really nice to have. It is a small sample size though. And then second, we didn't know whether like you guys were mentioning over here, Buzzies were available at these sites. We took them with us because we had the opportunity to have them on hand, but they're not necessarily available at all day hab centers or even at clinical sites when people are going for their doctor's appointments and getting vaccines, or even if you're going to the local pharmacy. And then a third limitation was the fact that we weren't able to really measure whether the vaccine uptake was improved after our education because we didn't have access to their medical records for the clients at the day hab centers.
Thank you, Vanessa. Like I said before, I'm Matthew Wagner, and I'm excited to talk about a little bit of the implications of our project. So from the beginning of our project, starting the planning, working with our wonderful community partners, and going through the process of the project and realizing its limitations, we came away with some key insights. And our first insight that we had was that we really lack appropriate education when it comes to educating community members, loved ones, and other caretakers of persons with IDD. So we definitely had room to improve, and that showed with our education. We saw clear improvements in those confidence scores at the day hab programs that we went to, but we also saw improvements in staff confidence and advocating for their clients at medical meetings or encouraging their clients to get vaccinated and educating them about the vaccines. That was one of our first takeaways. We also saw that medical education, as we talked about before, is really lacking for students like ourselves. And we really realized this as we took on this project, that we just do not get enough exposure to the needs of people with IDD versus the typical population. So we definitely want to address that. And then finally, we realized that the current efforts that are going toward vaccinating individuals with IDD are pretty dismal, despite the clear data that we're not doing a good enough job at it. So this project, we really want to in the future push it forward and improve this. With that in mind, we decided that we want to make our project sustainable for the future, and we want it to be something that our community partners and future community partners that we can expand to throughout Ohio can use this curriculum that we developed. So we wanted to develop a framework in order to educate community sites, loved ones, and caregivers of people with IDD, as well as the clients themselves, about self-efficacy and getting the pneumococcal vaccination. So first, we had some objectives that we laid out when we wanted to make this framework for education. Our first objective was for the caregivers, loved ones, to be able to identify pneumonia symptoms and the clinical presentation of pneumonia, to know when their loved one had pneumonia. Our second objective was to have these people learn how to better advocate for their loved ones or their clients with IDD in terms of getting those vaccinations when they're appropriate. And for that, we needed to teach a little bit about the CDC guidelines so they could get those vaccinations in accordance with that. And finally, we just wanted those caregivers, family members, and the clients to know the proper utilization of those pain control methods and comforting methods that we talked about, like the use of buzzies. There's another one called a shot blocker. It's a similar method of pain desensitization. And finally, just bringing a friend along if you really need one for support. That's always great to have a comforting presence there. And we just wanted to make sure people knew about that so they could advocate for their clients and for themselves when they're getting vaccinations or any kind of needle stick. And with all that being said, we do have this QR code here that you can scan. And if you have a PDF version of this, you could get to that as well. And this is actually a link to our curriculum, as well as the website where you can order buzzies for your clients and your sites if you're interested. Oh yeah. Yeah, feel free to scan it. And one of the other key takeaways that we really noticed with our sites that we went to was that all of the staff were really excited to get their hands on these buzzies and try them out for their clients. So that was really exciting to see such a optimism for using this. And finally, like I said, we have some lacks when it comes to medical education for students like ourselves, but we also know that most of our clinicians also are lacking that medical education when it comes to treating people with IDD. So we wanted to create another framework, which we're going to deliver to our residents at our clinic in the beginning, and hopefully expand to other clinics as well. And our objectives for this were first to have our caregivers, our clinicians, recognize the disparity that exists between the typical population and the population of patients that have IDD when it comes to these pneumococcal vaccinations. Second, we wanted our clinicians to understand those pneumococcal vaccination guidelines and the insurance coverage for those so that we can properly navigate that and make sure that it's covered when we give those vaccinations and that we can get those vaccinations as soon as possible to our clients without any hangups. And finally, we wanted those clinicians to also understand how to talk to their patients and how to use those pain control methods, those comforting methods in order to make the vaccination experience a more comfortable one. Yeah.
Good afternoon. My name is Salam Picard. And so I would just kind of like to summarize what you've all heard so far from my colleagues, right? So patients with IDD are more likely to experience higher rates of mortality due to illness, with respiratory disease being the second leading cause. And that gave way to our project. So we wanted to tackle pneumococcal vaccinations amongst the population with IDD. Clinical guidelines for healthcare gaps, such as vaccines that can prevent these serious illnesses, are often vague and incomplete. So we saw this throughout our project, and we wanted to help address this. And so even though there are these limitations, projects like this can help address those healthcare gaps within our healthcare system. The staff and clients were very receptive of our educational skits, and now have an increased interest in the importance of vaccinations. Like my colleagues mentioned before, the interest that came from this were the interest in buzzies, shot blockers, more information, and thus that helped us develop our curriculum for not only the clients and the staff, but for our clinicians as well. And ultimately, after our educational skits, the clients themselves at the day programs were more motivated to learn about how best to improve their own health, which increased self-efficacy and self-advocacy for adults with IDD. So we can see from this, throughout our project, we're hitting these certain points, but our main point was to increase self-efficacy and self-advocacy for adults with IDD. Now, before we move to the next slide, I just want to mention that these healthcare gaps was shown throughout our presentation, right? The age to get the pneumococcal vaccine is 65, right, for everybody. However, if you have different comorbidities, you can get it sooner. So even with our statistics earlier, we looked at a cohort, or the Cleveland Clinic looked at a cohort of age 65, both with people with IDD and the rest of the cohort. So even at the age of 65, there was a huge gap. So even though that they were able to get the vaccination earlier, that's something that I want to emphasize, because that is not acceptable in our current healthcare system in the United States. I just want to further go into why community partnerships are so important in healthcare. Thank you. Why community partnerships are so important in healthcare. Now, effective partnerships are essential for community-based solutions for advancing health equity and making it a shared vision and value, which increases the community's capacity to shape outcomes and foster multi-sector collaborations. Now, I just want to emphasize effective partnerships are essential for community-based solutions. If we don't have effective partnerships, then things aren't going to be accomplished. Now, sometimes, as health systems, we think, okay, we're going to make a community partnership. The best way we can help them out is donate to their cause. Now, that is a big, factor. Money is, in our daily lives completely. However, that is not an effective partnership by just donating to the cause. It's like programs and projects like ours, where we're not just helicoptering in, but we're actually trying to make this a continuum and a long-term project to help address these healthcare gaps. Partners are able to deploy unique skills and access resources to serve a variety of roles within our community, right? So they can deploy unique skills that sometimes healthcare systems are limited by. We're sometimes limited by, that square building, the hospital. However, community partners can deploy those skills that sometimes we cannot. Now, and my last point here is many healthcare leaders understand that health and well-being are created primarily outside the walls of our hospital systems. However, they struggle to orient their organizations to address this. Now, we understand that the upstream effects of health are happening outside of our building, yet we are focusing on the downstream effects. That's not what we should be doing. We should be creating these community partnerships to address those upstream effects so that we don't have to deal with the downstream effects. And so what are our critical takeaways for healthcare leaders, right? That's important too. So first, we want to recognize the journey toward health and the journey toward equity are the same. Let me, I guess, restate that because I stumbled. Equity. So if we truly want to improve the health of our patients, we need to understand that we need to provide it to the whole spectrum of patients. We need to make sure that equity is our number one, and thus we can address health for each one of our patients. We need to expand the notion of what a partnership is, right? So as like I explained earlier, a partnership is not just, okay, I'm gonna throw money at the problem and hopefully it'll get fixed, right? That is not an effective partnership because the solution ultimately is not gonna get solved. We need to understand what we're trying to accomplish with our community partnerships. So certain community organizations are oriented at addressing social needs. Some are addressed at, or oriented, excuse me, at addressing healthcare needs. So we need to find out which community organization best serves our purpose. Fourthly, we need to explore what is meaningful to both the health system and the community. For lack of a better terms, we shouldn't be forming these partnerships willy-nilly, right? We should understand what our community is lacking, and we should target that goal. As an example, pneumococcal vaccination. So that is a certain healthcare gap that our community is struggling with, or us as healthcare providers are struggling with. And we're trying to address that, and that's what we're trying to do. We have a specific focused goal. And lastly, we need to implement true co-design by aligning healthcare and community visions and goals. Right, so that means that when we meet with our community partnerships, when we are having those town hall meetings, everything's on the table. We don't have any hidden agenda. We don't have anything that's left unsaid because we need to be upfront with these community organizations. Because to be honest, right, when you're a community organization coming and talking with a big company like the Cleveland Clinic, first, it's completely reasonable to be standoff, right? What do they want from us? Why are they contacting us? So as healthcare systems and healthcare providers, we need to come to the table, be upfront, be open and say, we see that there's a healthcare gap here. Do you mind tackling this project with us? Now, lastly, I just want to focus your attention to this graphic that I have on the slide. This is the social ecological model of health, okay? So at the bottom, we have the individual. That's our patient population. Right now, we are hitting this at an organizational level, right? Professional organizations, associations, things like that, that's the healthcare system. However, if we truly want to influence the patient or the individual or the population at a higher level, we need to start contacting these community organizations, making partnerships with them, deploying those unique skills so we can help address those healthcare gaps within our communities. And thus the higher level would be policy, not only within our local municipalities, but with a state and federal level. So that's pretty much the end of our presentation. We'd just like to thank the staff and the clients at our day programs that we were able to visit, that being Ardmore, Welcome House, and Koinonia. We'd also like to thank the Ohio Professional Resource Association for letting us come to this conference and letting us present. We really appreciate it. We'd also like to thank our program director, Dr. Leanne Chrisman-Kwam, for just providing this knowledge set to us by filling in those gaps in our education, just because of how much need there are. We'd also like to thank Dr. Carl Tyler, who was our main partner with this project, because his community that he focuses on are those patients with IDD, and Mr. Lauren Anthus, who is our health system science professor, which gave us the foundation to make these projects and deploy them in our communities. These are our resources. And I would now like to open the floor for questions. Thank you.
So we have a couple, oh, sorry, yes. Does anybody in the room have any questions?
Yes.
I'm just curious on the cost of the fuzzy.
Yeah, so if you do a quick Google search and get on Amazon, there should be about 75 for the bag, like this kind of full kit that includes the buzzy, like a heat or cold compress, and then other miscellaneous things in there. You can do bulk ordering as well, and you can probably get a cheaper price through the website that's linked in the community guide that we had in our PowerPoint slide. 75. Yeah. For the single one, like on Amazon, if you go on there. Yeah.
Are vaccination rates lower overall in IDD population?
I can speak to that. And yes, they are lower overall in the IDD population. So that, which was kind of part of our project, in which we also had educational information about shots in general. And we also had our information graphic we made was also just about getting shots and being comfortable with them.
I thought we had a question online, but I think we got it answered, so. And now
One more question. I'm interested in learning how you do to incorporate information about being scared of shots. Is that just, I don't work in the IDD field myself, but is that just kind of a known that that's a deterrent to immunization, or is there data out there that shows?
Yeah, that's a great question. Where did you guys get that knowledge from? That's a great question. I do work in the field, but I'm curious.
Yeah, so we actually heard from our community partnerships and also from Dr. Tyler, the physician that we had worked with, that sometimes this population can show to have more like fear towards the pain of the shot, and therefore the buzzy is a great option to help with that and decrease some of the pain. And we have seen it work in clinic, which has been really good. Also within our curriculum, we do these like journal clubs where we look at the evidence and see how these things work. I actually did one that related to shot pain and fell upon one specific journal that related the buzzy to decreasing shot fear and pain. And it works not only in pediatric patients or patients with IDD, but also within adults too. So I think fear of pain and fear of shots in general is just such a common problem. And it's so nice that we have these tools that decrease that. I also add to that. Also, during our community meetings, we met with patients and asked them how they felt about shots and what their concerns were. And a lot of their concerns were that they didn't like them and that they were scared. So that's why we especially tried to address those.
So I guess I have a question for those of us that do work in IDD, they'll understand where I'm coming from. I'm curious if you guys, if you came across this or experienced anything negative, because obviously in these things, it's not always, you know, roses and flowers. Everything isn't always positive. We have a lot of folks with IDD that also, it's the opposite. They can get overstimulated very easily by touch, sounds, smells. Something like the buzzy could set them off and it wouldn't be good for them. Did you guys experience anything like that throughout this? I'm just curious.
So not particularly in this project as a whole, but me personally, I did used to work with the special needs community, like in high school, college, and a little bit into medical school. I have been involved into it. And I have a lot of experience with patients that do get overstimulated. And I think the emphasis on that is the fact that we just need to focus more on medical education and the relationships that physicians are building so that you can recognize and form better relationships with your patients so you can know an individualized approach. Like maybe this patient doesn't need maybe this is like the opposite approach of what I should be going with. So it's more, that aspect is more focused on medical education because we can't just be sending these physicians out into the world with no knowledge on this. A lot of them don't understand that like overstimulation is a huge issue and the not just the IDD community, but like people with anxiety. Like people with anxiety can get very, very, very overstimulated as well. And a lot of people with IDD also have anxiety. So there's a lot of confounding factors.